So welcome, everyone. Great to have so many people joining this Dementia and Older People's Mental Health Conversation session on memory assessment services. I'm Fiona Gowdy and I'm a clinical associate for Dementia and Older People's Mental Health with Yorkshire and the Humber Clinical Network. And we've got a really interesting agenda today. So with plenty of time, we hope for questions and hearing your inputs. The chat, as has already been mentioned, is there at the side. If people want to put questions in as we go through, we will, we're ably assisted by Colin. We will keep an eye on that chat and try and draw out themes for questions at the various points. So we're going to kick off with a national perspective from Mark Thaxter and Claire Fry from the National Dementia Policy Team, giving us a quick update on dementia diagnosis. Then we're going to be hearing about the national audit of Dementia 2021 findings from Jen Thompson, Network Delivery Facilitator at North East and North Cumbria Mental Health Clinical Network. So this is a double act across two clinical networks that you have today. Then we'll have some time for a bit of Mentimetering and discussion about the issues and challenges and innovative solutions that you might have that you're keen to share, and we're all keen to share and hear. Then we'll be hearing from Dr. Sarah Smith from Leeds Beckett University. We've previously had presentations at this meeting on the sharing good practice and innovation research that Leeds Beckett have been conducting over the last 18 months. So we're going to be hearing about the phase 3 findings, and then we'll have a bit more time for discussion and a final overview from the Mentimeter. So without further ado, I'm going to hand over to Mark and Claire. And I think at least one of Mark and Claire are going to be able to stay on the call this morning. So although you've got a short slot, there may be questions that people have for you. So we can kind of collect those up as we go through, if that's okay. So I'll stop and let Mark and Claire continue.
Brilliant. Good morning,
Welcome.
everyone. Thank you, and thanks very much, Fiona, and thanks very much, Colin. So on the call as well, we have Claire as well. Claire will be staying on for the rest of the meeting. I'll have to jump off, unfortunately, at around 10 o'clock. But what we want to do is just really give a brief overview of where we're looking at dementia diagnosis from a national perspective, what's going on, and some of the information insight we've found from talking to some memory assessment services as well.
Yep.
So it probably comes as no huge surprise that the dementia diagnosis rate has flatlined and has done so for the last sort of 18 months or so, really. We know that the target hasn't been met since March 2020 when the pandemic really hit. Obviously, through that time, we've been trying to understand what's been happening. We've been monitoring the situation with the regional teams in particular. And back in 2021-22, we managed to get 17 million for an improvement and recovery of the dementia diagnosis rate. Obviously, that's not a huge figure when you look at it in the round. And at the moment, it's still difficult for us to really assess what the impact of that has been. And partly because some of the projects that we found out about hadn't really started in earnest. So it could well be that there's a delayed reaction to it. And we are doing some work to follow up on the assurance process that was in place. So we're essentially trying to find out what has happened to some of that work and those projects. I mean, another question, of course, is what would happen had the 17 million not gone out to the system? We can see from the graph that's to the bottom right that new referrals to memory assessment service have increased to, and actually gone beyond, pre-pandemic levels. But what we're not seeing really is an increase in the number of people being diagnosed with dementia. And I'll get on some of those points shortly. We are trying to support some of this work, so we do have some memory assessment service dashboards that are upon our Futures platform as well. The idea is there to really sort of develop that data set so that we can use that to support local discussions and conversations. I think we'll just have a look now a bit about what's happening within the regions. So what we have here are the regional lines and how they've been performing in terms of the dementia diagnosis rate. As you can see, there's considerable variation, and that variation has gone on well before the pandemic hit. And to an extent, a lot of this can be disguised by the fact that we often look at just a national figure for the DDR. So only one region has really managed to sort of climb back up again, and that was London, and it was, or the northwest is very, very close to that as well. And both those have been quite high to that national ambition line for some time. You can see there, I've just highlighted the sort of northeastern Yorkshire one at 64.4% on the last returns that we had. And of course, within this, there is even more variation as well. So this just really highlights the ICBs within northeastern Yorkshire region. And in many ways, this is not dissimilar from graphs that we see in other areas as well, where there is that real huge variation. And as you can see from that line, you know, you've got one of the ICBs that's doing well, which is above the line. Another couple are sort of climbing up towards it, and then we've got the one at the bottom, which is sort of saying that that recovery really hasn't sort of set in, and they've come from quite a high position as well, sort of pre-pandemic. So some of this data really is just about trying to encourage those local discussions to understand what's happening more locally. And we've been doing some work to try and build a bit more insight into what's happening with memory assessment services as well. So we've taken some early findings that Colin managed to pull together for us from the region, and we've also been talking to people within the Midlands and other areas about what's happening with memory assessment services. Because I think it's very easy to sort of come down on MAS and say, well, it's because they're not performing, it's because this isn't happening, this isn't happening. The reality, I think, is very different. We didn't want to make assumptions about what's happening either. So what we've done is pull together some of our sort of initial findings into the next slide. So as we're heading towards Christmas, this is probably the Christmas cracker slide. I do apologise for the sheer amount of colour that's on the screen, and I can see that it's probably not the clearest thing in the world, but that probably represents actually really what's happening pretty well of itself. So I'll just talk you through a few things here. So at the start of the pathway on the left-hand side, what we've found is sort of often conflicting information, really. So some memory assessment services are saying that more people are coming forward, so more referrals are coming in, and in others, it's people are reluctant to come forward. It may well be what we've heard as well, that this is dependent on things like deprivation in the area. So in more deprived areas, people are more reluctant to come forward. But again, it's a generalisation. We haven't done enough work on that to understand exactly whether that's the case. We've also seen that the type of referral from GPs is changing, and there could be any number of reasons for this, whether that's because GPs are happier to send people through, whether it's because people are coming through with lots of different memory conditions and issues and concerns, which could not just be from dementia, but could well be associated with things like anxiety and depression. In any event, we've seen that waiting times are going up, and the next bit really looks at how we can maybe look at those pinch points as well, and to sort of encourage flow through. So moving into the Christmas cracker, so we know that there are other ways to diagnose. So Diadem and other models are available for diagnosis, although that's very much within a care home setting rather than through the MAS service itself directly. There's a role perhaps for GPs to play around diagnosis and identification, and indeed one of the innovations that's kind of come through is looking to employ GPs with special interest, or bring back retiring GPs to work just on dementia for a while, which can help with identifying individuals that may be at risk. Triaging, pre-diagnostic support all that's great stuff in terms of trying to relieve some of the pressure, but also to identify those that need to be moved through the system more quickly. We've heard as well in a couple of areas that memory services have essentially commissioned organisations like Age UK and using Admiral nurses to assess, which helps again with relieving some of the pressure. But the issue is that once those assessments have been done, the diagnosis needs validating by a medic, which is increasing then the pressure back into the memory service. We've heard as well that capacity at MAS in some areas isn't fully back to where it was, and some it is. But the problem is that because of the demands on staff and workforce, if people go on leave, if people are off sick, it just adds more pressure to the problem. Scanning and subtyping is another area. So some places are waiting a long time for both scans and for reads to come back. But we know that scanning isn't necessarily being used in the same way across all services, with some services wanting to use scanning all the time and others very little. So that remains a very localized issue. What we've also found then is sort of coming through the other end is that perhaps more people are coming through with diagnoses other than dementia. So in the one service we spoke to in the Midlands, pre-pandemic, it was looking at 76% of people coming through the memory assessment service ending up with a diagnosis of dementia, whereas now that's down to around 48%. So that's a significant drop. Mild cognitive impairment's increasing, but then we've also heard that there are other diagnoses, or in fact, people not being diagnosed and then being referred back to the GP. Within all this, of course, we can't just forget that the diagnosis is just one part of this. The availability of that post-diagnostic support is a really important factor in this as well. Getting a diagnosis isn't really much if there isn't anything to support you at the end of it. There's obviously differences in the way that memory assessment services work. So looking at the bottom couple of arrows, in some cases, diagnosis of MCI may mean that they're just sent back to the GP. In other instances in memory services, they're kept on their books and then are followed up sort of 6-12 months after that. So there is a difference in the way that that's being managed. There is also an issue with coding, and there's a sense that the records that are held by MAS don't always match up with that's in primary care. So a couple of places have employed people to essentially do some of that data cleansing work. There's also the issue, of course, with diagnosis that happens outside now of MAS. So whether that's sort of in secondary care, if that's within a CMHT or similar. And it's the question then about, okay, how does that then match up with the GP records? How does an individual get onto the dementia register? How are they followed up? How are they provided with the opportunity for post-diagnostic support? So complex. So along the top, there are then questions about, okay, the model that's in place and also the processes that are going on. Funding, there's this thing about, I think although there is no money around at the moment, certainly, but if we were to throw money at it, it's how would that actually work? So what can we really do potentially? And then there are sort of thoughts about workforce and competencies and whether or not something about building up those competencies, particularly within other roles that may be available either within primary care or within memory assessment services. So that's really, in a nutshell, or indeed a cracker, our findings so far on memory services. And we want to keep developing this, because if we are, as a national team, provide some sort of support to regions and then through to MAS, it's understanding what we need to do. And we just can't, as I said before, make assumptions about what the problems actually are. We need to be very clear on what the problems are and how they could potentially be addressed. Thank you very much.
Fantastic. Thank you very much. And absolutely bang on time there. So that was brilliant. So what I'm proposing is that we move on to Jen, which I think will be the other half of what you've started us all thinking about. And then when Jen has finished, we'll then have the opportunity for discussion, and I'm hoping that we can bring the two halves of the cracker together here. So over to Jen and Colin on the regional feedback.
So morning everyone, my name's Jen Thompson. I'm a network delivery facilitator for the Older Adult Mental Health and Dementia workstream in the North East North Cumbria Mental Health Clinical Network. And I'm joining the call this morning just to summarise the findings from a regional piece of scoping work which the networks undertook earlier in the year around memory assessment service provision across the region. And I'm also going to highlight some of the National Audit of Dementia 2021 findings and recap some of the recommendations from the audit. So before exploring the 2021 Spotlight findings, I thought I'd give some broader context on the National Audit of Dementia for those of you that may not be aware. So NAD is a clinical audit programme which is delivered by the Royal College of Psychiatrists, and it's commissioned by the Healthcare Quality Improvement Partnership on behalf of NHS England and the Welsh Government. It was established to understand the performance of general hospitals in delivering quality of care for people with dementia, and performance is assessed against a series of metrics linked with care delivery. The criteria is pulled from both national and professional guidance, so that's the NICE Quality Standards and Dementia Friendly Hospitals Charter. There have been 4 previous rounds of the audit in 2010 to 2011, 12-13, 16-17 and 18-19, and round 5 of the audit is proposed for rollout shortly. Alongside those rounds, there have also been spotlight audits on delirium, psychotropic medication and community-based memory assessment services in 2021, which I'm going to focus on in the next few slides. And just to recognise, the audit isn't compulsory, so your services may or may not have been involved previously. So as I mentioned, the Spotlight audit in 2021 did focus on community-based memory assessment services in the context of the pandemic. And specifically, the audit looked at access and waiting times, diagnosis and treatment, and post-diagnostic follow-up. And sampling focused on patients who were seen between January and August 2021. It's important to note that the audit is based on a National Memory Services audit undertaken in 2019 by the NHS London Dementia Clinical Network, further to audit work they undertook with London Memory Services in 2016 and 2019. And the data set for NAD 2021 does align quite closely with the 2019 audit to allow for direct comparisons in data where possible. The audit standards were the NICE guideline NG97 and also the Memory Services National Accreditation Programme Standards for Memory Services 7th edition. So in terms of regional involvement in the audit, North Eastern Yorkshire participation was 75%, with 9 NHS mental health trusts or health boards taking part. The audit collected data through 3 tools, and in brackets, the N value shows the regional sample as compared to the overall sample for each tool. The first tool was Case Note Audit, and that involved information being submitted on the first 50 to 100 consecutive patients seen at the memory clinics for an initial assessment from the 1st of January 2021. The organisational checklist provided service level feedback, and that related to organisational structure and provision at individual clinics and services. And the last tool was a patient feedback tool, and that was an online questionnaire adapted from a tool that Alzheimer's Society developed, looking at the feedback of people living with dementia diagnosed during the pandemic and their experience of virtual assessments. So the first key finding of the audit was around the impact of the pandemic, and data indicated over 70% of services nationally had experienced periods of closure throughout the pandemic. 62% of services reported being closed for between 1 and 6 months, and 83% of services reported having staff redeployed throughout the pandemic. The average waiting time for referral to diagnosis has increased by 36 weeks to 17.7 weeks, and that's up from 13 weeks in 2019. The recommendation on this finding is for services to use quality improvement methods to undertake active monitoring of waiting times for referral to diagnosis, and to identify problem areas and barriers to access to enable support for the ongoing recovery from the impact of the pandemic. The audit also highlighted the role of virtual appointments and adaptations that were made during the pandemic to support continued service delivery. So of participating sites, 86% reported offering patients virtual appointments, and 35% of patients did receive an initial appointment either by phone or video call. 45% also received an assessment at their usual place of residence. The report recommends that commissioners and dimensional regional boards should work with services to review their pathways for assessment, diagnosis and post-diagnostic support to ensure that support that is offered is both flexible and person-centred. They also emphasise the importance of engaging with service users and carers to understand their experiences and their priorities. So the audit emphasised the importance of completing all routine in-clinic assessments during an initial assessment for dementia, and the in-clinic assessments that were audited were visual and hearing loss, falls history and alcohol consumption. 92% of patients did have at least one in-clinic routine assessment completed, but only 43% had all 4 completed. In terms of individual assessments, 61% of patients had discussions recorded around eyesight, 58% around hearing, and 76% had a falls history discussed and recorded, which was an increase from 71% in 2019. The recommendation for services is to ensure that there is discussion around all in-clinic assessments, particularly hearing and sight tests, to ensure that other causes of displayed symptoms are excluded. And where a need for follow-up is identified, appropriate actions, including onward referral to services such as occupational therapy, should be carried out and documented. So on neuroimaging, only 43.3% of services stated scans were currently reported by neuroradiologists, and that had decreased from 76% in 2019. Analysis has showed CT or MRI scans were requested for 47% of patients, but as observed in the 2019 audit, there was quite significant variation in requests per service, ranging from 0 to 97.4%, and that suggested there was quite a high level of service and protocol level variation. So there was a specific recommendation made on neuroimaging, and that was that services should ensure that protocols for referral are in line with NICE guidance and recommended good practice assessed as appropriate per patient. So finally, the audit looked at post-diagnostic interventions, and all services that participated were found to provide at least one type of post-diagnostic intervention, with 62% of patients with either a working or a confirmed diagnosis of dementia being offered post-diagnostic support. The most common intervention provided was occupational therapy. Over 50% of services indicated that they were unable to currently provide carers with the opportunity to complete a psychoeducational course, compared to 26% in 2019. And lastly, 75% of services were found to be offering cognitive stimulation therapy across England, and it is recommended that services should ensure CST is offered or access to it is available for patients diagnosed with mild to moderate dementia in line with the NICE guidelines. So across the North Eastern Yorkshire region, we also undertook a separate piece of scoping work with memory assessment services in August 2022. The context for this piece of work was that it was recognised at a national level that the number of referrals to memory services between May and July of this year had exceeded those for the same period in 2019. But from the data collected, an equivalent increase in the dementia diagnosis rate wasn't observed. From this, there was an interest in understanding the key factors which may have been contributing to the regional picture and the national picture. And so we put out a regional ask through the clinical networks in August to gather insights into what the current challenges within the local systems were. We were also really keen to identify any new ways of working or good practice which could be shared throughout the networks. We received responses from 7 memory services, and 9 areas across the region were covered by respondents' feedback. So from the data gathered, we collated responses into 4 core themes, and as expected, they do align quite closely with the NAD 2021 findings. The first theme highlighted the impact of the pandemic, so feedback focused particularly on the experience and impact on patients and carers alongside service provision. System level factors was a broader theme, and that incorporated discussion around pathways, wider system pressures, funding and innovation. The role of workforce was recognised by nearly all respondents, and that looked at issues around recruitment and retention and staff absence. And finally, assessment and diagnosis focused on the current experience around referrals and access to scanning and scan reporting. So the feedback, which I'll present in the following slides, has been collated directly from the responses we received from memory services, and therefore any comments which I share will be as provided by respondents. So, as I've mentioned, feedback did emphasise that service recovery following the pandemic is ongoing, and in particular that was around managing the backlog following the temporary pausing of services, and also difficulty completing full assessments during the pandemic. A reduction in referrals has now led to services catching up and seeing patients who did not present in usual timeframes. And one service also mentioned that there's a degree of reluctance to return to face-to-face working. Several services acknowledge altered perceptions around the importance of diagnosis affecting achievement of dementia diagnosis rates. And it was noted that patient and carer perception of the importance of dementia may have reduced since the pandemic, with dementia being seen as potentially less important to other illnesses like COVID. Additionally, to quote one respondent, outcomes from dementia, such as care home placement, are also seen to be risky and undesirable. So inclination to seek a diagnosis and consequent care plan is seen to be lower at present than before the global pandemic. Another service also reported that following the pandemic, they've observed greater concern around memory loss as people have returned to their normal routines and noticed their capabilities have declined. So challenges in navigating pathways was reported. One service acknowledged that there had been difficulty in establishing consistency and oversight of local issues, particularly where there are multiple pathways in place rather than one or two core pathways. And there were several services that did report undertaking reviews of their pathways at present in light of increasing referrals and waiting times to assessment. Another factor identified was lack of regional or local commissioning intent and funding around the growing service demand. And it was felt that that could be a direct consequence of MATs not falling under mental health transformation work, but also not being integrated into the Ageing Well programme of work. Wider system pressures were also acknowledged, and that included a shift in focus to critical and crisis-related work in response to demand, with that being prioritised over more routine MATs work. In terms of demand, it was also recognised that building reputations as services, when done well, naturally results in an increased demand for those services. So, as previously mentioned, workforce was a common theme in nearly all respondents' feedback. Primarily, challenges around recruitment and retention were discussed. Respondents emphasised that services will only be able to diagnose the same amount of people unless there is an increase in capacity at both a staffing and a service level, equivalent to the increase in referral rates. Where there are staffing vacancies, challenges in recruitment were discussed, as well as high levels of staff absence and difficulties finding cover, and there being no backfill for those positions. The potential role for upskilling initiatives was described. So one service outlined their projects, including upskilling a Band 6 nurse to Band 7 to deliver diagnosis. There was an impact on the non-medical prescribing pathway and capacity for new assessments, but overall the pilot was reported as a success for the service and did improve their dementia diagnosis rate. Finally, the homogeneity and complexity of referrals to memory services was highlighted, and examples provided included forgetfulness with clinically significant impact and also diagnostic overshadowing through physical health comorbidities, polypharmacy, or treatment emergent events from medication which mimic a dementia presentation, all of which ultimately result in alternative diagnosis being produced. More primary care level awareness and potential case finding was also identified as having an impact on referral rates. Challenges with scanning was another common theme across services. So one service reported their trust recovery work resulted in only urgent structural brain imaging being undertaken and routine scanning being declined, therefore precluding robust diagnosis and subtyping. And another indicated waits of around 16 weeks for scans provided by their acute trust. Delays in scan reporting was also indicated, and that varied from 6 to 12 weeks across the services who provided us with that information. And finally, it was mentioned that greater awareness and a reduced stigma around dementia may have led to more people being inclined to seek assessment at earlier stages. So ultimately, our aim for this work was to provide insights and foster a shared understanding of what the current system challenges were, further to the impact of the pandemic and ongoing system recovery. But we were also really keen to identify solutions which are in development or may have already been developed across the region and could be shared with others. There were some comments around solutions in response to our scoping work, and they were particularly focused on developing new ways of working and sharing knowledge. So some areas that were identified included managing capacity and demand, exploring the role of the voluntary sector, understanding different workforce models and how they can support the diagnostic process, identifying approaches to pragmatic diagnosis, including the use of diadem in hospital or community sectors, and developing data sets which recognise the wider work of memory services beyond just the dementia diagnosis rate. So we're going to post a Mentimeter question shortly on this, and would just welcome you to share any solutions which you may be working on or areas where support would be helpful. So thank you for listening. These are the contact details for Colin and myself, and we'd love to hear from you if you have any other feedback or any questions you'd like to share. And I'll pass you back to Colin and Fiona to do the next section. Thank you.
Thank you very much for that, Jen and Colin, for the data collection and a very helpful presentation, which I think does align very much with Mark and Claire's high-level national messaging too. So, Catty,
Yes, so we've got
have I got
Catty.
that right? Yeah. Okay, Catty,
Yes.
over to you.
Hello. In Wakefield, we've used an initiative for pre-diagnosis process. We work with care coordinators. We've had a number of dementia roadshows, and we ask care coordinators to attend our roadshows in a private room to offer memory test, 6 CIT tests to facilitate, for some people it's not easy to go to GPs, to book appointment with GPs. And they ran number of 6 CIT tests for people that they struggled with memory, and they signed the agreement. So share the information with the practice each person was registered with, and asked to do further tests, to go for blood tests if it's indicated any memory issue. So 6 CIT test doesn't need to be done by GPs. It can be done by other professionals, and to send them for to start the process of going for blood tests and try to eliminate the other reasons that can contribute to memory problem. So that was the initiative, worked quite well, and this is something that we're promoting.
That's great. Thanks, Catty. That's helpful to hear about that kind of primary, secondary, and broader example. And also, I think what you were touching on there was interoperability in terms of data sharing agreements, which I think is a kind of really useful point. Okay, any other hands or questions in the chat?
There's no more hands up. Fiona, just in response to what Catty was just saying, I wonder if I could sort of ask Catty, I wonder if has any data been sort of taken around whether any of those tests that were those 6 CIT tests went on to become a dementia diagnosis, because that would be a useful exercise to find out.
I can find out about it. Just I need to go back to care coordinators, and if they allow to share the outcome. But we made sure that data sharing, everybody to sign the agreement prior to do any test, because it was sharing with Alzheimer's Society as well as with GP practices, different practices. Yeah, I can get back to you.
Okay, thank you.
I'm just sort of looking at the Mentimeter here, the things I can see. So there's some good examples of, I'm just seeing something there from Kirk Lees about
Dementia Hub.
Yeah, that's right, post-diagnostic support, which is interesting given that kind of national point that's been raised about people staying on caseloads or not, and so it's interesting to see that the Dementia Hub function here being used. So there's a mixture here, aren't there, of assessment, diagnosis, support pathway, and post-diagnostic support as well. So it's good to.
Yes.
And if people feel free, if people are willing to actually be contacted, I think it would be helpful for people to put their contact details in the chat, would it, Colin? So I'm sort of conscious I'm conscious that people have put this on the Menti, and so we've got some really good examples here. But in terms of us being able to make links between people or follow up, if people are willing to put their kind of specific emails in the chat, that would be great, because I'm conscious that's not going to show up on the Mentimeter.
No.
Okay, any other questions?
There's no questions in the Kirklees have put. I wondered not to put Jacqueline on the spot, but because you've put that in the Mentimeter, Jacqueline, would you be happy to say a few words about what you're doing in Kirklees? Forgive me for putting you on the spot.
You've got mute on, I think. You're on mute.
Yeah, I think you're on
Thank
mute.
you.
Jacqueline.
Hi there, I'm Jackie from Kirklees Dementia Hub. We've worked alongside Folly Hall Clinic in Huddersfield and Priestley Unit. So anyone that is diagnosed is, with consent, automatically referred into our service for post-diagnostic support, which could be telephone. We can arrange home visit, and we've just recently developed a community hub in a library for families to come along and talk to us about various things. We offer things like personal plans, which is really for people who don't really have much understanding of dementia, and they maybe don't know what's available in the community. They might not know about things like attendance allowance or groups they can join, or specific courses that carers can attend as well. We've got a very good service, Kirklees Wellness Service, who offer carer support and things like local carers services like Carers Count, who offer lots of different services. They're a fantastic service. So we do a lot of information, a lot of signposting within the local community, and there's a lot of fantastic voluntary groups as well that a lot of people tap into. So that's just a kind of flavour very quickly of what we offer.
Thanks ever so much,
Thank you.
Jackie. And I'm picking up there again that point about interoperability, something about consent, enabling flow of people, between services rather than improving that access and support. Question from Christopher: is the evidence of lower conversion rates possibly an unanticipated outcome of widening the pool of referrers beyond the usual GP or consultant groups? Oh, and this is mirrored in Calderdale too. Oh, sorry. Is what's being mirrored in Calderdale the Jennifer Goodwin?
Yeah, it's the Calderdale Dementia Hub. So we have a very similar situation that Jackie was just explaining. So we're the memory service.
The hubs.
So the hubs. Yeah.
Yeah. Oh, great. Yeah. Okay. So you got a similar service. Yeah. And yeah, and see that we've got a link there. So that question about conversion rates, I don't know if Jen, Colin, or Claire from the national team want to respond to that, or is it that we know about that, or is it a work in progress? Claire, I think. Do you want to? Oh, well, Mark's still on the call. Great.
Yeah,
I don't mind it, Mark, if you wanted to.
I'll go for it, Claire. Fine.
I was just going to say, obviously, we have been having a number of conversations with providers. In terms of, I suppose, broadening the pool, we are trying to obviously establish why there are different diagnoses coming through around anxiety, depression, MCI, but I don't know, certainly as I understand it anyway, the main referrers are still primarily through general practice. I know that there's been suggestions and discussion previously about broadening referrers and maybe getting them in from hospitals or even self-referral. I think you can do that in Scotland, but which we are trying to ensure understand why this is happening. We don't have any definitive answers at the moment.
Yeah. Thanks, Claire and Mark. Yeah. Okay.
There is a hand up, Fiona.
Yes, I see that. So is it Caroline Ryder-Jones?
Hi, thank you. Yeah, I'm Caroline. I'm an OT working in a memory service in Teesside, and I'm just curious. Although this is anecdotal, we seem to be getting a lot more referrals of people who have alcohol-related issues, and there's the challenge between abstinence and diagnosis and some of the protocols around that. And I just wondered if nationally or regionally that was something that people had noticed.
Great question. So nationally or regionally, is that something that people have noticed?
And if so, what you're doing about it.
Yeah, Claire, Jen, Colin, anything you want to say, and indeed others on the call, you know, if this is more than anecdotal, what are your thoughts?
I think it's a really interesting point. It wasn't something that was picked up specifically in the data on the feedback that we got, but I would definitely reflect it back to the group to see if there's anyone else on the call who's noticed similar findings in their areas.
I think interestingly linked in with that, at the point at which we were submitting the data for the audits, it hadn't quite filtered through at that point, I don't think. Just thinking back to when we were doing some of that, but probably in the last 6 months or so.
Yeah, I mean, it's something, I don't know if Mark and Claire have got a view on that, but it's, I mean, certainly when we're collecting data from a clinical network perspective, we kind of don't get the reasons for the referral, so it wouldn't come across our table. But I'm not sure if it's mentioned in the NAD audit, Jen. I think there is a mention of it.
I was going to say it's quite interesting. It's not a statistic I explicitly mentioned in my presentation, but around the routine in-clinic assessments, the statistic from the 2021 audit was 78% of patients did discuss their alcohol consumption, and that was up from 50% in 2019. So it's quite interesting to see that there has been quite a significant increase in that figure. And I wonder whether that does reflect, you know, what you're saying anecdotally.
It's interesting. I'm noting that Sarah's put a comment in the chat. So, and hopefully, you know, we might get onto this with Sarah's presentation, that support or lack of for people with alcohol-related dementia came up in the national survey.
Yeah.
So I think you might be onto something there, Caroline. My hunch is this is not just anecdotal, but you know, as has been said, we've not necessarily collected some of this data, but it looks like there's something coming up in the national survey. And another comment here from Kate in the chat. There's a shift in the types of referrals. I've not quantified these, wondering whether there's a generational shift. Yeah. Liz Copley, Ardash. Hi, Liz. I don't think the alcohol-related referrals have increased in your services. That's that in Ardash, but we'll check. Interested to know the abstinence protocols used elsewhere prior to offering assessment. That's an interesting one. I'm going to just throw in from the chair an observation that I think, you know, the rise in alcohol-related problems in older adults more broadly, and the fact that pathways are not joined up, you know, so you know, community mental health transformation and dementia pathways. I wonder whether we're missing a trick there. Just putting that out there. So CMH. CMHs, I think, may be seeing a rise. Are we working jointly on this? Are we looking at our older adult CMHs and asking them about work on alcohol in older adults more broadly? Because I think that theme is coming up. So that would just be an observation. Okay.
The national audit, that if people haven't seen the NAD audit yet, we will send out a link. I think there's a link at the end of your presentation, Jen, to the national audit, and you should be able to access regional audits as well. I don't know if people on the call have seen their sort of regional report, but we'll send links out afterwards so that you can.
And Jen, thank you very much for putting that in the chat. That's fantastic for everybody to access. Yeah, so thanks for your comments. Brilliant. Thanks for the Mentimeter sharing and the examples. Really interesting. I think we've posed some very good questions here and food for thought, to which we will no doubt return. Welcome, Sarah, and thank you very much for agreeing to join us to share phase 3 of the Innovative Practices in Memory Assessment Services project, which has, I think you've previously visited to update us on phases 1 and 2. So this is you know, great to have you, and over to you and your presentation, and then we'll we'll be able to have some discussion as well, hopefully. Okay, so welcome, Sarah.
Thank you, and thank you for inviting me back to talk about the last phase of this project. So I am going to recap on some of the early phases as well, just as a reminder, but I will focus on the later parts. And I do think it probably just really nicely builds on some of the discussions that you've already been having today as well. So hopefully we'll fit in and just extend some of those discussions. So this is a project that was funded by NHS England and started probably, like Colin said, probably around kind of 18 months ago. And it's had two parts of the project, and we're on to the final part. We were commissioned initially just to kind of look at what was happening in memory assessment services, both in England and Wales, how they were commissioned, in order to try and derive some recommendations and examples of good or innovative practice. So that was broadly the remit of the project. I won't go over too much of the background, but we know there are around 3,300 memory assessment services in England and smaller amount, 22 in Wales, and they're all commissioned and operate in many different ways. And obviously, as people have alluded to, that was hugely affected by COVID. Many memory assessment services stopped and then restarted. So we were conducting our work in the context, I think, of memory assessment services just kind of restarting in December 21. So we were looking at providing an overview of memory assessment services so that, as I say, we could share some of those examples of good or innovative practice. And we're in phase 3 now, and that's what I'm here talking to you about today. But we've had 3 phases of the project. The first one, we developed a kind of practice development and innovation guide that's a practical guide for supporting people who are looking to extend or develop their memory assessment services. In the second phase, we did a survey, and in the third phase, we've done case studies, and I'll talk about each of those in a little bit more detail, just so that you can access some of those resources if you want to go back to them. So the practice development guide is available and I can share it through Colin, and it's also on our website. But this was developed in consultation with an expert working group. Some of you might be in the room today, comprising of kind of clinical network representatives, clinicians, and also our steering group, our lay advisory group. And what we did is we looked at published standards and guidelines, and then developed this guide for supporting continued development and practice innovation. So if you want to, you can download that from our website. It was launched in March this year, but the aim is not to kind of set out any standards or kind of benchmarks. It's just ideas for developing your practice, essentially. It's quite aspirational, but thinking about how you might address some of the areas of need within your service. So the survey that I think I presented last time I came to this group, so I won't go into any detail in this, but we conducted a survey that was basically just looking to kind of capture what services looked like in England and Wales at that time. And we intended to, we used the areas of the practice development guide as structure for the questions that we asked in the survey. And we essentially asked people what their service looked like at that time, whether it had been affected by COVID, whether they were adopting any changes that had come about because of COVID in terms of delivery and design, and also any areas of need for the service and anything that they were doing in relation to kind of innovative or good practice to address those areas of need. We had 49 responses that we included in the survey in the end. Generally, people in terms of approach said that they were now using blended approaches, which they hadn't been doing before COVID, but that face-to-face approaches were still what they perceived to be the gold standard. And I thought that was quite interesting, Jen, because that didn't seem to necessarily correspond with your regional survey that you conducted. So that might be interesting to look at, because some of our services, I think around a quarter of services in England, were looking to go back to just face-to-face models and felt that was the gold standard. And many services, even when they adopted a kind of more blended approach, still were looking to retain those face-to-face models as well. So we also looked at the workforce, and 78% of respondents said they had gaps in their workforce. Fewer but 45% of respondents said they had gaps in the way that their service was commissioned and what they were offering, and 78% said they had plans for quality improvement. Again, we'll put this in the final report, so I'm not going to go into detail of the survey findings, and I've presented them here before. But one of the things that we did in the survey was we used the survey to identify case studies that were demonstrating good practice. So for those survey respondents that had identified something that we thought was really interesting, we went back to those and we used the survey to inform the case study approach that we then subsequently took. I have just put here some of the findings from the survey in terms of the workforce needs, and they do broadly kind of match on to some of those, I think, Jen, that you'd reported into. So in terms of the workforce needs, there was a general feedback around we don't have capacity, we've got issues with referral volume versus staffing volume, some more specific challenges around support for MCI, not having pathways for MCI, not having sufficient workforce to inform post-diagnostic support, and then that issue with kind of relying on external services, particularly with in relation to kind of neuroimaging services as well. In terms of the service needs, broadly following those themes, people were reporting they don't have enough support for MCI, less common forms of dementia, and actually that's where that alcohol-related dementia support came in as well, in terms of those qualitative responses. People reporting not having enough resource or services to support post-diagnostic support, including carer support. So broadly, the workforce themes mirrored the service needs that were identified as well. We then asked people about ideas they had for innovation and best practice. So this is the part of the survey that informed the case study identification. So people referred to practice around streamlining workforce and recruitment. So kind of extending roles so that they could deal with a number of diagnostic referrals coming in, using approaches like floating consultants, training in-house staff to do things like phlebotomy and ECGs, remodeling existing pathways, so not necessarily huge changes, but just thinking about how they could do that, as well as introducing new services and interventions. So improving access to biomarkers came under that, new cases to support new pathways like MCI services. And some of these were ideas that people had already had prior to COVID and had been interrupted due to COVID, and some of those came out of the kind of issues that arose with dealing with the backlog following the COVID crisis. So we used some of these findings to inform our case study methods. So we had specific criteria for our case study sites. We wanted them to demonstrate at least one example of good or innovative practice. You'll see, as it turns out, because of the complexity of memory assessment service, we'd go and talk to them, and actually they were doing one thing really well, but also probably more than one thing really well. So often they demonstrate more than one area of good practice in reality. But we were looking for that one to identify them. That was judged by using the survey and taking that to our steering group and lay advisory group. So we had a huge amount of case studies that were potential sites, and we took those to our meetings and we discussed them, and we said, actually, this is a really good, strong case. And we were looking for things like, is there a kind of clear way that people have asked for this model to be commissioned? So they're really kind of pragmatic, and we've tried to articulate them such that if you had an issue, for example, with meeting needs to support people with MCI, you can look at someone that's developed an MCI pathway and see how they got that pathway commissioned, and then go and talk to that person, see if something that you want to emulate in practice. We wanted to kind of represent a range of geographic locations and also a range of delivery methods as well. And once we'd identified a site, what we did is we went to the lead who'd completed the survey for that site and arranged to do interviews at that site over Teams, and there were either one-to-one interviews or small group interviews that we conducted, obviously remotely. Where possible, we also got kind of supplementary documentary evidence to help us to understand the pathway at the site. And we also asked at every site if we could speak to service users as well that had experienced the pathway. that wasn't always possible, and you'll see how often that happened, but we did ask that at every site that we went through. And then for the analysis, we've looked at the key themes that have been coming up in each site. And you'll see, I'll show you the structure of the case studies, and we've tried to present them in a structured way in the report itself. So this is just to give you an overview of those sites. So we ended up with 15 sites, 13 in England and 2 in Wales. At some sites, we were able to do quite a lot of interviews, you know, 4 staff interviews and interviews with service users. In some sites, it was just really challenging to get those interviews. People are very busy. Sometimes it's not always easy to follow up service users. In those sites, for example, that had just gone through MSNAP accreditation, they already might have had access to people that they talk to. So the pathways were already there for us to go and approach people. So it was a bit easier. So we have a range of kind of different numbers of interviews completed at different sites, you know, and a range of different staff that took part in those interviews as well. So typically we had at least a psychiatrist or a psychologist at a site, and then other staff that worked at the site too. And then when we can, we had service user interviews. And this is just to give you an idea of the kind of themes that have been coming up in the case studies. So how we've presented this in the report is that in the survey threw up some areas of need that people were experiencing in memory assessment services. So we've tried to demonstrate which case studies link back to the themes that were raised as areas of need in the survey. So a really big area was post-diagnostic support, so, for example, and you can see there that it's very small, I do apologise, 1, 2, 3, 4, 5, I think 7 of the case study sites had something specific in terms of innovative approaches to post-diagnostic support. So we did try and cover a breadth of different features and themes with the case studies, but some of them reflecting the area of need are covered more than others. So we've got post-diagnostic support, we've got things like personalised care pathways, and by that we're kind of being quite specific. That's where case studies have covered things like people coming in, they've got a really kind of clear triage assessment for putting people into different pathways based on need and presentation. So we've got integration of services. That I think that comes on some of the things that you were talking about, Fiona, in terms of interoperability and some innovations around that. Support for MCI and rarer dementias. Neuroimaging actually wasn't coming up a huge amount, but we do have a case study related to that. Things in terms of equity of access, so that relates both to kind of people living in different geographical regions and also issues of diversity. Technology, use of multidisciplinary teams, examples of working with external services, which could be kind of VCSEs and third sector organisations as well. Specific QI projects and interventions. So these are things that might have got funding or people are looking for funding for, but are relatively new. Streamlining services, things like specialist diagnostic support. So that might be kind of introducing things like neuropsychology into services. We had quite a lot of case studies using specialist staff, and then the location of memory services. So this is where memory services were located somewhere different. So for example, in primary care or reaching out into community organisations. So that's the kind of overview, and I cannot go into detail on all of them today, but I'm just going to give you a quick sight of the description of some of those case studies and get through as many as I can. So I can share these slides with you afterwards. They'll be in the report. I think you've got a feel, hopefully, for some of the themes that are coming out of them. And I've just picked a few just to give you an idea of what they might look like today. But I think they do echo some of the conversations that you've already been having in Mentimeter, and I can see some of those things are already happening in the region anyway. But hopefully this gives you an idea of the kind of thing that we've looked at in detail and how people are making that work for them. So I'm going to look at Site 2, Site 5, Site 7, Site 9 and Site 11 in brief. So Site 2 we were interested in because it was commissioned to provide support from referral to end of life. So post-diagnostic support came up as a huge issue, and this was one of 2 services that we looked at that had an extended period of post-diagnostic support, and this was for everyone who came into the service from referral to end of life. And for everybody coming into the service, they had a 1-month post-diagnostic review and then 6 monthly reviews, which could be increased with frequency if there were issues that put someone into crisis, essentially. All of those reviews were undertaken by an assistant practitioner or nurse, depending on how complex their needs were, and at least one review was conducted in the person's home. So that team was quite a broad team, but it did include occupational therapy and psychology staff. So this was a service that was specifically commissioned to provide this level of post-diagnostic support. And we've got some detail in the case about how they went about getting that service commissioned and what that looks like as well. So obviously one of the main challenges with this model is just dealing with the numbers that people had on their caseload. So we've got some detail of that in the report, but it's about 170 to 180 for the assistant practitioners and 60 to 70 for nurses. So obviously, you know, that could be a really big issue, but we've got some kind of practical advice and some direct quotes from the people that we interviewed in the case study about how they manage those caseloads. I'm not going to read the quote for you because it's there, but just to kind of give you that first-hand account of what that looks like, and then also the benefits of what people have. And I think broadly one of the things that they talk about in this case is kind of becoming then embedded in wider community resources as well, knowing what services are out there, and through that kind of ongoing support, kind of working and raising awareness of what the memory service can do. They've worked with GPs as well, who seem much more willing and able to refer to them, potentially because of the ongoing support that those people are receiving within their service. So that's one of the cases. Shall I just go through them, Colin, and then kind of stop at the end for questions? Is that the best thing?
I think so.
Yeah, that's fine. And if
so,
people want to chip in on the chat while you're talking, we'll try and collect those questions up at the end.
Thanks, Fiona. So case 5, we focused on because of its different approach to the assessment and diagnostic end of the pathway. So this is a psychology orientated and a psychology led assessment and diagnosis service. So it's a specific service for assessment and diagnosis. They're not commissioned at all to offer post-diagnostic support. But what they do have is a really kind of clear triage system and different pathways based on patient need. So in their own words, they're not under or over assessing the patients that are coming into the service, which gives them the opportunity to offer a more person-centred pathway and person-centred approach. So their service includes a range of kind of clinical psychologists, occupational therapists. From memory, they don't have a medic that sits within the service, but they have a medic that is within the remit of their team. So they kind of have a 4-stage system, I think, for kind of non-complex models. They go straight through. I don't even think that they offer neuroimaging. I can double check that for those. Yeah, so they have a pathway that's kind of a non-complex pathway for people with really established cognitive impairments. They've got the mainstream pathway that's for people who are older adults coming into the service, who are offered a neuropsychological assessment. They've got a specific psychology pathway for more complex presentations. And they've got a kind of formulation pathway for people who might have another underlying issue but wouldn't present as meeting the threshold for dementia. So generally, one of the things in their pathway that I guess was quite novel is that their assessments not conducted by non-medic trained staff. And to enable them to do that, they've had a really bespoke model of training, which they've developed in-house. And that means that nurses and OTs and psychologists can obviously deliver the assessment and the diagnosis, which makes it it has increased capacity within the team. So it covers quite a big region, this memory assessment service. And there's more detail in the case about how they developed their training and how they've shared that within the team. So that's kind of the unique presentation of case 5. So case 7 is providing culturally tailored assessment and diagnostic support. So this is an urban region with a high South Asian population. So this was developed in response to potentially not getting the numbers of referrals they're expecting from this population. So they worked with primary care to kind of address myths about dementia and highlight the potential benefits of seeking a diagnosis. And they've also developed a culturally appropriate assessment tool. So they do offer post-diagnostic support, but that's contracted out, and they want to expand that offer as well. So just to kind of think about the impact of this kind of approach, they've had a 30% increase in referrals to the service from this community group. Some of the qualitative feedback is really nice. They talk about people not getting as anxious when they're coming to the service. And we do have quite a lot of feedback from people who've used the service in this case study as well, saying that they found it very accessible, they found the test easy to understand. So we've got quite a lot of nice informal feedback around the approach that they've been using for assessment as well in that case. Case, how am I doing for time? So case 9 was a kind of one-stop shop. This was again in a more urban region in the northwest. So they have a 12-week pathway, and most of the time they're meeting that pathway. So the two novel elements for this is the kind of one-stop shop, which means that people are coming into a dedicated clinic and getting most of their assessments and workup done in one day. And the innovative component is the brain health assessment and support. So this is a model where essentially one consultant at the moment is intercepting people between referral from the GP to the memory assessment services in the region, and is reviewing those people, identifying those that probably wouldn't meet the threshold for a diagnosis of dementia, but nonetheless have some kind of presenting or subjective cognitive impairment, and then is offering those patients a full assessment and some kind of support or onward referral to another service. So through that is kind of reducing inappropriate referrals and reducing the pressure on services across the region. But at the moment, that's not something that's been commissioned. It's something that he's gathering evidence around, but just showing how we can kind of meet that need for people who are potentially lost in other services. And we've got some really nice kind of quotes around what kind of support you can offer for the people under those umbrella as well. So finally, case 9 is this case where so it's another brain health type intervention, but also looking at post-diagnostic support in the community. So this is a case that's worked really closely with their community organisations. So there is one central team, but memory assessment services are being offered out in the community at different sites using GP practices and different kind of community sites to offer both assessment and post-diagnostic support. So following the diagnosis, people are referred to agencies, and they are then referred back to their GP at 3 months. But a lot of that post-diagnostic support is being picked up by the local Alzheimer's Society. And I think that one of the things in this case that really struck us was the idea of brain health sessions as a means to getting out to people, to enhance people's awareness of dementia and brain health issues that will filter eventually back into the use of the service. So in those last 2 cases, 2 really different approaches to the idea of brain health as an intervention for catching people, but also a means to reduce pressure on traditional memory assessment services. So I hope that gives just a flavour. There's so much in the report, I couldn't possibly go over everything. But we have tried to structure the cases so that there's a summary at the top of each of the cases. As I said, we've got the themes which kind of index where they might be in the report. And then we've asked people things like what led up to developing the service in that way, what does the service offer, what have the challenges been, and what are the benefits of the service. And for I think all of them now, we have those contact details so that if you find it interesting, you can contact the service directly. So really it's kind of signposting people throughout. So that's what the overall final report will look like. It will include the survey findings and the case study findings. And we're hoping, we need to get it signed off, obviously, by NHS England, but it should be ready kind of January, New Year time. But I'm very happy to share the slides and answer any questions or anything else in full.
Fantastic.
Thank you.
Thank you. Thank you, Sarah. that is really a great sharing and hearing about those case studies. And as somebody who was involved with the project, it's really great to get this kind of hot off the press in advance. And my question was going to be, when will it be shareable? And January is what you're saying, but in the meantime, it's fab to have the slides. So. Yeah. Questions. I can see that we've got one in the chat already from you, Colin.
Yeah, it was just when I was listening to you talk about case 7 that they developed a culturally sensitive assessment tool, and it's whether things like that in all of the case studies, I guess there'll be some innovative practice. Are you going to share that as part of the piece of work?
Yeah, so
people on this call would.
Yeah, we probably won't share the tool itself, but we share the details with the contact at the Memory Assessment Service. And I think there's so much in there, that's kind of the best that we can do. But there was honestly so much appetite for promoting what people were doing at each of the sites. I think that's something to reflect, that people want to share, you know, the tools that they've been developing, and there's so many resources I think that are there that will be available. And in the context of the cultural assessment tool, there's some kind of mention in the case about the validation and the aspiration for validation, and I guess sharing on a larger scale might facilitate some of that happening as well. So yes, it's a tool that I believe people would potentially be happy to share if you contact the person directly, but it wouldn't be kind of appended in the case or anything.
No, okay, no, that would be good.
Right.
I mean, we've had lots of conversations about culturally sensitive tools in the past, haven't we? And I'm sure that there'll be lots of people on this call and in the memory services who would be really interested in seeing that. But yeah, that'd be good.
So, are there any other questions for Sarah, or indeed for any of our other speakers this morning at this point?
No questions in the chat at the moment. But
right, hands or chat or chat is fine.
Either, so.
Yeah. Okay. Well, I've got a I'm not sure if there's a question or a comment. Well, a comment, and then was I thought it was interesting that so many of these examples were, you know, what is characteristic or what they have in common is that they've been able to work with the commissioners, and I think that seems quite an important point, that because of course we have quite a lot nationally within kind of memory services of creeping developments. You know, it's certainly been, you know, kind of characteristic of the development of services over the last 30, 20 years plus. When I think about it, you know, services have been set up, and the research has not necessarily been ahead of practice. Practice has often been ahead of research, and research has then come in on the back of it. So that's been very characteristic, I think, of memory services in the 25 to 30 years that I've been involved with them, looking back over my career. So I think it is interesting, actually, that these examples we've been able to get in there with working in partnership with commissioners, and maybe that's something to be thinking about given the challenges that we've got. So let's see. I'd be interested in people's thoughts about that. I can see there are a couple of commissioners on the call. Will the report? Okay, a question from Tessa. Tessa, do you want to ask your question, or do you want me just to read it out? Happy for you to ask your question. Okay, I can read it. So the question, Sarah, is: will the report be explicit about how young onset dementia is included in the memory assessment services featured? I don't know. So can you respond to that one, Sarah?
Mm-hmm. Yeah, so we do have a couple of sites that were chosen on the basis of their support for younger people. So one of those was site 4, So again, both had two features. So one of them was a memory hub for people in an over 65 pathway, and one of those was a specific pathway for younger people, because it was identified as an issue in the survey. So we did want to choose case studies on that basis. So they talk about how they refer into the service, and the support for younger people in that service is to the point of 65. So they have kind of a lifelong service for their younger onset pathway. And I think one of the really interesting things, Tess, I'm going off on a tangent, apologies, but one of the interesting things in that pathway was they're also going through a process, because people have been on their caseload for so long, of reassessment of some of those individuals, and some of those people are being reassessed and then not, being de-diagnosed in a way, because they then haven't progressed, so are no longer meeting the threshold for having dementia. So that case talks about how that's being dealt with as well, and I felt that was quite kind of innovative practice, because obviously that involves quite a lot of support to go through that process with people. So we do have some of the cases that focus on younger onset dementia and pathways, but it was identified as an issue, so it's not explicit in all of the cases, because some of that is missing as a service in some cases. But it's in that one, I think, another one as well.
Thank you. Anything else in terms of questions?
No. We've got a quiet group today.
It's fine. Question for Sarah.
Yeah.
Liz took a question for Sarah about site 1, and also a question for Liz. Do you want to
come in, Liz?
Yeah.
Do you want to come in, because you've got a complex question?
I know it's a bit of a lot.
No.
What I was, there's been lots of discussion about the challenges around workforce, and obviously that's something that we are struggling with in Sheffield as well. So I was wondering, it's a question for Sarah with regard to site 1, but also with regard to Jennifer for the survey that you've done as well. Have we got a picture across the region around the different roles that are being used within different parts of the pathway? I can almost imagine some kind of, I think this is the kind of thing that Penny and Colin often email us around, some kind of table that says these are the types of roles that do this part of it, and these are the types of roles that do this part of the assessment. I just wondered, have we got that? And if not, is that something maybe that we could share, that we could collect some information on? I think it would be helpful to be able to understand what other people are doing and what's working elsewhere.
I mean, so in the cases, that is explicit in the cases, Liz. So in site 1, I just checked as well. So it's the nurses and OT that are assessing and doing the primary diagnosis, and then that's going on and being discussed at an MDT. So it is explicit in the cases where that kind of approach is being used, and also sometimes how people have trained people to get to that point to be undertaking those roles. The other thing is more broadly, and it doesn't answer the question in as much detail, as in the survey we did try and get a picture of all the different staff that were making up the workforce within each of the memory assessment services that responded to the survey, but it doesn't break down what roles people are undertaking in terms of the assessment and diagnosis and post-diagnostic support. But hopefully that's highlighted in some of the cases, so you would be able to pick that out.
Yeah.
Thanks. Thanks very much for that, Sarah. I'm just
part to that question.
Yeah.
That was for Jen.
Yeah.
For our questionnaire. I don't know if you want to go, Jen, and I'll chip in.
Yeah, no problem. I think in terms of the scoping work we did, when it came down to specific roles and responsibilities, the examples around upskilling were primarily where that information came from, where people had given examples of upskilling band 6 to band 7 to deliver diagnosis. It wasn't an area that we specifically asked about, so it was only sort of when those examples were given that we've got that information. But I think in terms of solutions moving forward, looking at different workforce models was mentioned as something that people were really keen to get more information on, and I think we're keen to kind of look action focus going forward. What can we be looking at further? And it may be that that's something that we do go back to services to kind of get that information explicitly, if that is something that's helpful to share with others.
Okay. I'm seeing a couple of comments and questions here. So there's a comment from Liz Copley about variation being a concern, given that great examples of innovation, but services are not necessarily either developed or commissioned to and there's no centralised governance on this. I don't know if that's a comment that Claire, the national team, might want to address. And then there's a question, I think, from Caroline Ryder-Jones about is that advanced practitioners that you're asking about? Are those roles being developed to extend practice? So do you want to who wants to respond to those questions? Either the individuals that have raised them or on the workforce front, do we know about those roles specifically?
Fiona, sorry, just sorry.
Claire, do you want to jump in on the national governance question, and then others can jump in on the workforce?
Sorry, I apologise. I'm being messaged through other meetings as well. So can you just repeat the question for me?
It was okay. So it was a question. It was a comment that it was great to see so many examples of innovative practice.
Yeah.
But that there's a risk that this is idiosyncratic and people might not get access to some of these. People won't get access to these innovations nationally. There's a concern that there's no strong centralized governance on this. So I guess, I've just flagged this as what the kind of national view would be on this, kind of idiosyncratic innovations, and what are, what the thoughts might be about this variation.
We totally agree, and variation is something that very much needs to be addressed from our perspective. And in actual fact, we are actually trying to draw together a sort of a 4 nations group, so we can agree sort of good principles around memory service activity, and also in terms of what's being provided as well. And I think it'll help with the necessary leverage to support change moving forward, certainly from a commissioning perspective. That's where it's very early stages at the moment, and I think the earliest the meeting can happen is probably January, seeing the dates that have been flying around recently. But we will keep everybody informed of any developments in that area. Thank you.
Yeah, no, that's very helpful to hear about. Okay, so that I think responds to that, to Liz's question, I think, if that's okay. And then the workforce point about is there anything either from Jen or from Sarah, Jen, Colin and Sarah, about I'm presuming, is that approved clinician posts, or you might need to just define, or are we talking advanced practitioners might just need to have something there about definition? But I think the question really is about whether these sorts of roles are being developed to extend practice in memory services, and whether either in the innovation work or in the audit work you're picking that up.
Are you answering that, Sarah?
I mean, I can do, yeah, certainly in the survey where we looked at the workforce makeup, kind of advanced practitioners were reported as undertaking roles within memory assessment services, and some of the case studies have picked up where that's happening as well. So just, yes, I guess that is definitely happening within some memory assessment services.
Great, thanks. Okay, so that's, yeah, advanced practitioner, advanced clinical practitioner roles. Okay, anything on the audit front in terms of utilisation was come out in relation to those roles? Not specifically. No,
I think
okay.
Echoing what Sarah said,
yeah.
There were a few examples given, but as I said, it's mainly around the upskilling front, and a few pilot schemes that had been being run. But I don't know if anyone on the call it may be doing work in that area that they'd be interested or willing to share with the group.
Well, please do put it in the chat and we'll share it.
Yeah, do.
Thank you.
I mean, I think the other thing to say on that, Fiona, is that, through heard, haven't we, that there are teams that are looking at all kinds of different innovative ways to, to manage the workforce issue, because the workforce issue is an issue for not just in memory services but across the board. So yes, I'm sure that that all teams are looking at various ways that they can upskill different members of staff, and that may something that as a clinical network we're interested in sort of working with the MAS teams to, to look at how, how that's happening in different areas, and taking some of the case studies that Sarah's presenting, and and looking at everybody's sort of pathways, and using forums like this to kind of share that, and sort of learn from each other in a sense.
Yeah, no, I think that's right. I mean, I'm conscious that the sort of clinical associate psychologist's role, there's been talk about that role being expanded to have more of a health and physical health function. So I can see that they're often used in kind of the diagnostic bit of the pathway, but I'm hearing from a colleague in Sheffield about this being a part of a broader national conversation. So again, that might be a bit of a watch this space in relation to broadening roles. Obviously, the voluntary sector work that's been described. I'd got a question. So I'll take chair's privilege if we've not got lots of other questions. It was really about whether anything in the case studies in relation to the voluntary sector work touched on how we ensured access to training and to competencies, kind of sharing of competencies, sharing of training, and sharing of quality improvement, because we sort of subcontract some of our work to voluntary sector partners, but do we ensure that the Health Education England offer and our own offer as health providers addresses the potential variation there? So I just wondered if that was something that, if we're commissioning something, or if we're saying, okay, Alzheimer's Society are going to be involved in doing the post-diagnostic pathway, but how do we ensure kind of that shared understanding, shared skills, shared training, and so on? Just wondered if any of the case studies touched on any of that.
It's a really good point, Fiona. I'm off the top of my head, I'm not sure. And for the included sections in the case studies as we have them now, I don't think it features. I don't believe it features in terms of that quality assurance. But I can make a note of it and go back to people that conducted those case studies at those sites and ask if they're in the wider transcripts, and we can go back and look at them. But honestly, off the top of my head, it doesn't seem that it's been a priority, most certainly. And there have been other training features in some of the case studies, but not extending out to the support that's offered by VCSEs and Alzheimer's Society. Yeah.
I'm just conscious that it's come up in HEE discussions about who can access training, and as we increase our use of voluntary sector partners, what's our offer back? So it's just something I'm kind of
very interesting
I'm just something I'm conscious of. Also, Andrea, is that a question or a comment? I think it's a comment. So in the chat, we've 6-month upskilling of band 6 to 7. Yes, somebody else mentioned this. I think Jen mentioned this. So I don't know if it's a cross reference. Yeah, Brill. To deliver diagnosis, and they've managed to diagnose 150 patients, now permanent post, and that's in response to not being able to track me. So that's that whole kind of to what extent do you need a medical input to the pathway? And of course there was a case study there, wasn't there, in Sarah's presentation about non-medical diagnostic.
And really nice feedback from the service users about using that pathway as well. So yeah.
Andrew, did you want to say any more on that? Okay, are you all right with sharing if people want to be in touch?
Fine. Yeah, that's fine. I mean, we also do have because we've been trying to recruit an additional medic post for quite a few years now, and been very unsuccessful in doing that, which is a great shame. But it did lead to a member of the team being upskilled, and as I said, that's been made into a permanent post, which is fantastic. And they really have had a massive impact on that waiting list. So they deliver diagnosis. Obviously, it's to clarify, they're not making that diagnosis, it's the delivery of the diagnosis to confirmed Alzheimer's / mixed dementia patients. So the complex patients stay with the medics. We do have another band 6 nurse who is not going to be upgraded, and they're also a non-medical prescriber who will be delivering diagnosis to patients that they have assessed at initial assessment, where there's a clear-cut diagnosis. So we are looking at all options that are available.
Great, thank you. And I think that theme of, kind of non-medical diagnosis is it's considerable in some services and not so much in others. So it's an interesting variation there that we might return to. Thank you to our speakers. Really thought-provoking. And very significant updates from the national and regional kind of audits. So that's really helpful as well. And I think it's also quite inspiring to hear about some of these innovations. So I feel the session, really kind of fell naturally into two sides of that cracker. So thank you. Thank you, everybody. Thank you, our speakers, and thank you all for participating.